Patient safety goals. Improve the safety of patient care in healthcare organizations. Patient identification. Goal 1. Improve the accuracy of patient identification. Goal 1. Improve the accuracy of patient identification. Use at least 2 patient identifiers when providing care, treatment, and services. Use at least 2 patient identifiers when administering medications, blood, or blood components. Use at least 2 identifiers when collecting blood samples and other specimens for clinical testing, and when providing treatments or procedures. Do not use the patient's room number or physical location as an identifier. Label containers used for blood and other specimens in the presence of the patient. Eliminate transfusion errors related to patient misidentification. Before initiating a blood or blood component transfusion, match the blood or blood component to the order. Match the patient to the blood or blood component. Use a 2-person verification process for matching or a 1-person verification process accompanied by automated identification technology, such as barcoding. When using a 2-person verification process, one individual conducting the identification must be the qualified transfusionist who will administer the transfusion. The second individual conducting the identification verification must be qualified to participate in the process, as determined by the hospital. Improve communication. Goal 2. Improve the effectiveness of communication among caregivers. Goal 2. Improve the effectiveness of communication among caregivers. Report critical results of tests and diagnostic procedures on a timely basis. Develop written procedures for managing the critical results of tests and diagnostic procedures that address the following: the definition of critical results of tests and diagnostic procedures, by whom and to whom critical results of tests and diagnostic procedures are reported, the acceptable length of time between the availability and reporting of critical results of tests and diagnostic procedures. Report critical results of tests and diagnostic procedures on a timely basis. Continued. Implement the procedures for managing the critical results of tests and diagnostic procedures. Evaluate the timeliness of reporting the critical results of tests and diagnostic procedures. Hand-off communications. Implement a standardized approach to hand-off communications. Include an opportunity to ask and respond to questions. Provide up-to-date information regarding the patient's condition, care, treatment, medications, services, and recent or anticipated changes. Verify information either by repeat back or read back. Limit interruptions during handoffs. Provide an opportunity for receiver of information to review relevant patient data. Medication safety. Goal 3. Improve the safety of using medications. Goal 3. Improve the safety of using medications. Label all medications, medication containers, e.g., syringes, medication cups, basins, and other solutions on and off the sterile field. Label medications and solutions that are not immediately administered. This applies even if there is only one medication being used. Label any medication or solution when it is transferred from the original packaging to another container. Labels include the drug name, strength, quantity, diluent, and volume, expiration date when not used within 24 hours, the expiration time when expiration occurs in less than 24 hours. Labels are verified, both verbally and visually, by 2 people. Verify all medication or solution labels both verbally and visually. Immediately discard any medication or solution found unlabeled. Remove all labeled containers on the sterile field and discard their contents at the conclusion of the procedure. All original containers from medication or solutions remain available for reference in the perioperative procedural area until conclusion of procedure. All medications and solutions are reviewed at shift change. Reduce the likelihood of patient harm associated with the use of anticoagulation therapy. Use only oral unit dose products, pre-filled syringes, and pre-mixed infusions when these products are available. For pediatric patients, pre-filled syringes should only be used if specifically designed for children. Use approved protocols for the initiation and maintenance of anticoagulant therapy. Before starting a patient on warfarin, assess the patient's baseline coagulation status. Use a current international normalized ration, INR, to adjust therapy. Document the patient's baseline status and current INR in their medical record. Policy must be written to address baseline and ongoing lab tests required for anticoagulants. Provide education to prescribers, staff, patients, and families regarding anticoagulation therapy. This includes the importance of follow-up monitoring, compliance issues, drug and dietary interactions, and potential adverse drug reactions and interactions. Evaluate anticoagulation safety practices, take action to improve practices, and measure the effectiveness of those actions on a regular basis. Maintain and communicate accurate patient medication information. Obtain information on the medications the patient is currently taking when admitted to the hospital or when seen in an outpatient setting. Document in a list or useful format for those who manage medications. Define the types of medication information to be collected in non-24-hour settings, emergency department, primary care, outpatient settings, and different patient circumstances. Information that may be collected includes name, dose, route, frequency, and purpose. Compare the medication information the patient brought to the hospital with the medications ordered for the patient by the hospital in order to identify and resolve discrepancies. Provide the patient with written information on the medications patient should be taking when discharged. Explain the importance of managing medication information to the patient at discharge. For example, instruct the patient to give a list of updated medications to the patient's primary care physician. Healthcare-associated infections. Goal 7. Reduce the risk of healthcare-associated infections. Goal 7. Reduce the risk of healthcare-associated infections. Comply with current World Health Organization, WHO, hand hygiene guidelines, or Centers for Disease Control and Prevention, CDC, hand hygiene guidelines. Adherence to hand hygiene has been shown to terminate outbreaks in healthcare facilities, reduce transmission of antimicrobial resistant organisms, and reduce overall infection rates. In addition to traditional hand washing with soap and water, it is recommended that healthcare personnel use alcohol-based hand rubs. The use of gloves does not eliminate the need for hand hygiene. Likewise, the use of hand hygiene does not eliminate the need for gloves. Comply with current WHO or CDC hand hygiene guidelines. Continued. Healthcare personnel should avoid wearing artificial nails and keep natural nails less than 1/4 inch long if they care for patients at high risk of acquiring infections. Remove gloves after caring for a patient. Do not wear the same pair of gloves for the care of more than one patient. Change gloves during patient care if moving from a contaminated body site to a clean body site. Healthcare personnel should decontaminate hands before having direct contact with patients, before donning sterile gloves, before inserting indwelling urinary catheters, peripheral vascular catheters, and other invasive devices that do not require a surgical procedure. Healthcare personnel should decontaminate after contact with patient skin, body fluids or excretion, mucous membranes, and wound dressings. Decontaminate after contact with environmental surfaces in immediate vicinity of patients. Antimicrobial wipes may be considered as an alternative to washing hands. Implement evidence-based practices to prevent healthcare-associated infections due to multiple drug-resistant organisms. Conduct periodic risk assessments for multi-drug-resistant organism acquisition and transmission. Educate staff and licensed independent practitioners about healthcare-associated infections, multi-drug-resistant organisms, and prevention strategies at hire and annually thereafter. Education should recognize diverse roles of staff and licensed independent practitioners and be consistent with their roles. Educate affected patients and families about healthcare-associated infection strategies. Implement a surveillance program for multi-drug-resistant organisms based on the risk assessment. Measure and monitor multi-drug-resistant organism prevention processes and outcomes, including infection rates using evidence-based metrics, compliance with evidence-based guidelines, evaluation of education program. Provide multi-drug-resistant organism process and outcome data to key stakeholders, including leaders, licensed independent practitioners, nursing staff, and other clinicians. Implement policies to reduce risk of transmitting multi-drug-resistant organisms that meet regulatory requirements and are aligned with evidence-based standards. Implement a laboratory-based alert system, either manual, electronic, or combination, to identify new patients with multi-drug-resistant organisms. Implement an alert system to identify readmitted or transferred patients with known positive multi-drug-resistant organisms. Implement evidence-based practices to prevent central line-associated bloodstream infections. Educate healthcare workers, upon hire and annually thereafter, about central line-associated bloodstream infections and the importance of prevention. Prior to insertion of a central venous catheter, educate patients and, as needed, their families about infection prevention. Implement policies to reduce risk of infections and that meet regulatory requirements. Conduct periodic risk assessments, measure central line-associated bloodstream infection rates, monitor compliance, and evaluate effectiveness of prevention efforts. Provide associated infection rate data and prevention outcome measures to key stakeholders, including leaders, licensed independent practitioners, nursing staff, and other clinicians. Use a catheter checklist and standardized protocol for central venous catheter insertion. Perform hand hygiene prior to catheter insertion or manipulation. In adult patients, do not insert catheters into femoral vein unless other sites are unavailable. Use an antiseptic for skin preparation during central venous catheter insertion that is cited in scientific literature or endorsed by professional organizations. Use a standardized protocol to disinfect catheter hubs and injection ports before accessing the ports. Evaluate all central venous catheters routinely and remove non-essential catheters. Implement evidence-based practices to prevent surgical site infections. Educate healthcare workers, upon hire and annually thereafter, about surgical site infections and the importance of prevention. Educate patients and families as needed about surgical site infection prevention. Implement policies and practices to reduce risk of infections and that meet regulatory requirements. Conduct periodic risk assessments for surgical site infections, monitor compliance, and evaluate effectiveness of prevention efforts. Measure surgical site infection rates for the first 30 days following procedures that do not involve inserting implantable devices, and 1 year following procedures that do. Provide infection rate data and prevention outcome measures to key stakeholders. Administer antimicrobial agents for prophylaxis and for a particular procedure or disease, according to methods cited in scientific literature or endorsed by professional organizations. Implement evidence-based practices to prevent indwelling catheter-associated urinary tract infections, CAUTI. Note: This NPSG is not applicable to pediatric populations. During 2012, plan for the full implementation of this NPSG by January 1, 2013. Planning may include a number of different activities, i.e., assigning responsibility for implementation activities, creating timelines, and pilot testing. Insert indwelling urinary catheters according to established evidence-based guidelines that address the following: limiting use and duration to situations necessary for patient care, using aseptic techniques for site preparation, equipment, and supplies. Manage indwelling urinary catheters according to established evidence-based guidelines that address the following: securing catheters for unobstructed urine flow and drainage, maintaining the sterility of the urine collection system, replacing the urine collection system when required, collecting urine samples. Measure and monitor CAUTI prevention processes and outcomes in high-volume areas by doing the following: selecting measures and monitoring compliance using evidence-based guidelines or best practices, evaluating the effectiveness of prevention efforts. Risk assessment. Goal 15. The organization identifies safety risks inherent in its patient population. Goal 15. The organization identifies safety risks inherent in its patient population. Identify patients at risk for suicide, applicable to psychiatric hospitals, and patients being treated for emotional or behavioral disorders in general hospitals. Conduct a risk assessment that includes identifying patient factors and environmental features that affect suicide risk. Identify individuals at risk for suicide while under the care of or following discharge from a healthcare organization. This is an important first step in protecting and planning the care of these at-risk individuals. Address the patient's immediate safety needs and most appropriate setting for treatment. When a patient at risk for suicide leaves the care of the hospital, provide information such as a crisis hotline to individuals and their family members. National Patient Safety Goals Universal Protocol. Eliminate wrong site, wrong patient, wrong procedure surgery. Eliminate wrong site, wrong patient, wrong procedure surgery. Conduct a pre-procedure verification process. Implement a pre-procedure process to verify the correct procedure for the correct patient at the correct site. Involve the patient when possible. The frequency and scope of the verification process will depend on the type and complexity of the procedure. The purpose of this verification process is to make sure that all relevant documents and related information or equipment are available prior to the start of the procedure, correctly identified, labeled, and matched to the patient's identifiers, reviewed and consistent with the team's understanding of the intended patient, procedure, and site. Identify the items that must be available for the procedure and use a standardized list to verify their availability. At a minimum, these items must include the following: relevant documentation. For example, history and physical, signed procedure consent form, nursing assessment, and pre-anesthesia assessment. Labeled diagnostic and radiology test results. For example, radiology images and scans, or pathology and biopsy reports that are properly displayed. Any required blood products, implants, devices, and/or special equipment for the procedure. Match the items that are to be available in the procedure area to the patient. Mark the procedural site. Identify those procedures that require marking of the incision or insertion site. At minimum, sites are marked when there is more than one possible location for the procedure, and when performing the procedure in a different location would negatively affect quality or safety. For spinal procedures, special intraoperative imaging techniques may be used in addition to preoperative skin markings. Mark the procedure site before the procedure is performed, and, if possible, with the patient involved. The site is marked by the practitioner, who is ultimately accountable for the procedure and will be present when the procedure is performed. Site marking may be delegated to an individual who is permitted by the hospital to participate in the procedure in limited circumstances. The method of marking the site and type of mark is unambiguous and is used consistently throughout the hospital. The mark is made at or near the procedure site and is sufficiently permanent to be visible after skin preparation and draping. A written alternative process is in place for patients who refuse site marking or when technically or anatomically impossible or impractical. A timeout is performed before the procedure. The timeout must be conducted in the location where the procedure will be done, just before starting the invasive procedure or making the incision. The timeout has the following characteristics: is standardized as defined by the hospital, is initiated by a designated member of the team, involves the immediate members of the procedure team. A timeout should be performed between procedures when doing 2 or more procedures on the same patient. During the timeout, the procedure team agrees, at a minimum, on the following: correct patient identity, correct site, procedure to be done, completion of the timeout must be documented. The amount and type of documentation will be determined by the hospital.